say thank you so much to you for offering to do the opening session of this new year of 2023. Would you like to start and just tell us a little bit about yourself and your background and how you came to be in radiology and how you came to be a consultant in Great Ormond Street, and then we'll let you launch into your lecture. So over to you.
Sure. So I moved to the UK only a few months ago. Prior to that, I did my fellowship in Paediatric Neuroradiology at Sick Kids in Toronto. And before that, I did general pediatric radiology fellowships in Australia and in India. I think I decided to do pediatrics because I found it challenging and there was a need for subspecialization, which I thought was unmet. Pediatric neuroradiology per se, I think, again, that was a subfield of pediatric radiology that I found a lot more challenging, a very steep learning curve. But once I started reporting more and more cases, I mean, it kind of became a sort of challenge to get better at it, and therefore the fellowship followed, and now I'm here. So I've been working at GOS now since March of 2022, and yeah, it's great to be here. I love the job, and yep.
Well, I'm delighted. Well, the UK is the huge benefactor for having you, and that's great that you're enjoying your job. I'm very pleased to hear that. London can be quite hard to live in, and but that I think the GOSH staff are very welcoming, so they'll be very pleased to have you on the staff. So Ashley, I'm going to let you carry on. We're looking forward to hearing your lecture, and then Bovio is going to finish off and field questions and things and at the end.
Okay.
Thank you again, Ashley.
No, thank you.
You okay there?
Yeah.
That's great. We can see your screen. Thank you
Okay.
so much. That's
great.
Thank you.
Good evening, everyone. Thank you, Prof, for the warm introduction. Thanks to Fulvio as well. Very happy to be here and share a brief talk on pediatric neurometabolic disorders, a topic that is quite near and dear to me. Before we begin, I would like to request you to look at 5 different cases. Make a mental note of these cases, what the findings are, and just mentally come up with either a primary differential diagnosis or a list of differential diagnoses. So this is case number 1. A neonate born normal, which is an important bit of history, and developed encephalopathy on day 7 of life. So we have axial T2 weighted images here at different levels, and then we have diffusion weighted images from the vertex down below to the level of the brainstem. So questions are, what is the pattern of involvement and what is the most likely diagnosis? Moving on to case number 2, again, a very similar theme, born normal, lethargy and poor feeding that started on day 3 of life. Again, we have axial T2s and diffusion weighted sequences, the B1000s at different levels. What is the most likely diagnosis? What may be the underlying mechanism for these imaging features? Case 3, so a slightly older child, now 13 months old, male with progressive spasticity and weakness, So we have axial T2 weighted images, the supratentorial compartment, the posterior fossa. So what's the long tract involved in this case? There's a few tracts involved in the posterior fossa as well, and some additional imaging to provide further clues of the optic chiasm and cauda equina nerve roots. These are post-contrast T1 weighted images. And what is the likely pathomechanism? Case 4, back to our neonatal group, seizures on day 7 of life, born normal. Again, these are axial diffusion weighted images, sagittal T1 weighted image, and an MR spectroscopy. So what is the pattern of involvement and what is the most likely diagnosis? And finally, case number 5, a 6-month-old on treatment for infantile spasms. Spasms are well under control. Baby is otherwise well. This MRI was done to evaluate for the cause of spasms. And this was what was seen. Symmetric changes on diffusion and an axial T2 through the level of the posterior fossa. What is the most likely diagnosis? Okay, so the outline of my talk is going to be highlighting the importance of early recognition of in neurometabolic disorders. So I'll start off by briefly discussing a few important concepts in neurometabolic disorders, followed by a pattern-based approach. The aim essentially is to provide a starting point and a roadmap to approaching these disorders. Ultimately, at the end of the talk, we hope to be able to solve those first 5 cases using the concepts that we have learned. The most important point I would like to stress is that many neurometabolic disorders are potentially treatable, at least to varying extents. Depending on the etiology and severity, some are fully curable, some others are, we are able to achieve a state of so-called metabolic homeostasis, in which case further neurological decline and acute episodes of metabolic decompensation are prevented. So early initiation of treatment halts progression of brain damage and in some cases also potentially reverses the changes that have already occurred. So what is our role as radiologists? It's mainly twofold. We are often the first sentinel clinicians to recognize that this particular patient could have a metabolic disorder. And then we must do our very best to attempt at least to narrow down the differentials based on a pattern recognition. It's not always possible to come down to a specific diagnosis, but oftentimes we are able to narrow it down to either a particular enzyme pathway or and sometimes imaging is quite specific for certain diseases, and we'll see examples of that. So the first concept, although a simple one, it is useful to remind ourselves that the neurological features ultimately come down to either accumulation or deficiency of a specific metabolite. So consider a scenario where in the normal instance, molecule A through a number of enzymatic steps is converted to molecule Z. If there is a genetic defect that leads to either deficiency of this enzyme or its cofactor, this process is hampered, and this will manifest in disease in one of two ways. That is, if molecule A acts as a toxin, and can be either water soluble or water insoluble toxin, we'll come to that later. Or if deficiency of molecule Z leads to an energy deficient state, as in this case, which is a case of mitochondrial cytopathy. The second important concept I would like to stress is that a fairly large group of these disorders are present at birth. They are known as devastating neonatal metabolic disorders because if they're not diagnosed and treated early, they tend to have permanent neurological damage. These disorders are generally the result of accumulation of water-soluble molecules. And the typical scenario of these cases are they are born normal. This is an important bit of history, unlike perinatal hypoxic ischemic injury, where they might be born floppy or encephalopathic. And then after a variable symptom-free period, which can be a few hours or a few days after birth, they become ill. The symptoms are often non-specific. They tend to have encephalopathy is a common feature. The others would be lethargy, poor feeding, seizures, etc. And these are triggered by a diet or illness. So in utero, they are protected by the feto-placental circulation and feto-placental metabolism. But after birth, once they start feeding, if they're unable to tolerate the feeds for any reason because of an enzymatic process, they tend to decompensate. So this time period, this variable symptom-free period is an important concept to remember. Treatment, of course, would entail reduction of the toxic metabolites. Example, in this case of maple syrup urine disease, protein restriction is key. And then eventually these findings can be potentially reversed, as in this case where you see a very good outcome. In older children, older children can have, again, repeated episodes of acute metabolic decompensation due to water-soluble molecules. But another pathology is the accumulation of complex molecules. So these are storage disorders, and they generally occur slightly later in onset because it takes a few weeks to months for the accumulated toxin to actually cause neurological damage. So again, the typical scenario is that they are born normal, with the notable exception of peroxisomal disorders. So that's Zellweger syndrome and its spectrum, which tend to have cortical malformations as a result of the metabolic defect. And therefore they may be born, with seizures and other symptoms. But otherwise, the majority of these cases are again born neurologically normal. They may or may not have some dysmorphic features depending on what the etiology is. And then accumulation of the complex molecule takes time, weeks to months or even years, depending on if the enzyme deficiency is partial or complete. And this eventually leads to progressive neurodegeneration. As you can see in this case of GM1 gangliosidosis, over time there has been accumulation of these complex molecules. The thalami is commonly involved here with this T2 darkening. You also have degenerative changes, abnormal myelination, and also striatal changes. This patient also, it's essentially a systemic disease. So you have skeletal dysostosis with abnormal shaped bones and dysplastic looking radius and ulna that we see here. This is probably one of the most important things to keep in mind, is that certain toxins or deficiency of certain molecules affect certain anatomic structures in particular. And this can be elucidated by looking at two different examples. So there is a common theme to these three different cases, in that there is restricted diffusion. As you can see, it's very symmetric. It involves the perirolandic region, involves the ventrolateral thalami, and then the brainstem. You see the optic tracts are also involved, in cerebellar white matter. Similarly, in case 2, you have involvement of the perirolandic white matter, the internal capsules, and to a lesser extent of the brainstem. Case 3 is also similar. Essentially, the only difference is that there's a lot more swelling and a lot more involvement in this case, but all three have a very similar pattern of involvement, and that involves the white matter that is expected to be myelinated at birth. So whatever disease process is driving this eventually has led to what is known as intramyelinic edema, which is also known as myelin splitting edema. And we'll see why that happens. And these are three different conditions: maple syrup urine disease and MMA and non-ketotic hyperglycemia. All of them are categorized as devastating diseases, devastating inborn errors of metabolism with a very similar imaging phenotype. There are subtle differences to differentiate these. For example, the MR spectroscopy over here shows a glycine peak, which helps us differentiate NKH from MMA. So intramyelinic edema essentially is separation of the layers of the myelin sheath. It's also known as myelin vacuolization, and it is more commonly seen in very young infants with metabolic decompensation. Sometimes it's also seen on account of certain medications. So we saw intramyelinic edema. This is a slightly different pattern. The common theme in all these three cases is that thalami are very dark on the T2 weighted images. In the first case, we also have a T1 which shows bright thalami. The other common theme is that they all have abnormal white matter. So you have T2 dark thalami and abnormal white matter in all three cases. Again, there are subtle differences. For example, in this case, you have a lot of cerebral and cerebellar atrophy, whereas in this case, you have dilated perivascular spaces and again, very dysplastic appearing ribs, which help narrow down the differential diagnosis in this case. So these are storage disorders, and so you can see that they take some time to accumulate. The thalami is a useful clue on T2 weighted images. And these over time, since they are neurodegenerative conditions, you would see worsening over time if they are not treated. And that is evident, especially in this case where you have progressive atrophy. MR spectroscopy is a useful tool, and it can be used to assess accumulation or deficiency of certain molecules. The caveat that it should never be used alone. It should always be used in conjunction with the other routine sequences and in the clinical setting. Just a very brief diversion into what MR spectroscopy is. It's a form of functional imaging, and it essentially reveals the metabolic status of the sample region. The three main metabolites that we see normally are the NAA, that is a marker of neuronal viability, creatine, which is a marker of energy reserves, and choline, which is a marker of cell membrane integrity and turnover. And depending on the type of MR spectroscopy we use, that is either a short TE that is 35 to 44 milliseconds or a long TE. Many centers also use an intermediate TE of 144 milliseconds. The metabolites that we see are different in the sense with a short TE, we see a lot of the more minor, so-called minor metabolites such as myoinositol, which are not seen on the longer TEs. So our interest is not only in looking at these metabolites, but also in looking for branch chain amino acids in the case of maple syrup urine disease, lactate, which is a surrogate marker for anaerobic metabolism. So any process that leads to anaerobic metabolism can lead to an increase in lactate. Glutamine and glutamate, which are seen in uracycle defects, galactitol in galactosemia, and many others. The normal spectrum, again, depends on the age. So in neonates, because they are, they have an immature brain, they have a high cellular turnover. So as expected, the choline, which is a marker of cell membrane turnover, is high. and the Na is low because the neurons are not mature yet. And then over time, it normalizes. By the age of about 2 to 3 years, you see the adult, the expected shape in adults where you have Na being the highest peak and then creatine and choline. Normally, we don't see any of these other smaller lactate peaks unless there is a disease process. Okay, so these are three different cases again, and this is just to show how MR spectroscopy helps in giving in giving specific diagnoses actually to these conditions. This patient is a 7-year-old with autism and developmental delay. Structurally, the brain was completely normal on imaging. There were no acute changes. But MR spectroscopy, as you can see, shows an absent creatine peak. So this is cerebral creatine deficiency syndrome. And in this particular case, we could only make the diagnosis because of MR spectroscopy. The second case, we've seen this before. You have involvement of the internal capsules. So again, myelinated white matter, but again, is this methyl malonic acidemia, or is this because of elevated glycine? That can be answered with the help of MR spectroscopy. So you can see a peak at 3.5 parts per million, which represents the glycine peak, helping us differentiate these two conditions. And finally, the third case, again, very symmetric changes on diffusion. This pattern is quite typical for urocycle disorders, and I'll show you an example of that later on. But there are atypical patterns, and in cases of MRS in this case, helps to actually confirm the diagnosis when you see elevated glutamine and glutamate peak right next to your Na peak. And a very practical concept, if you see any in radiology, if it's very symmetric, it's either normal or it could be a toxic or metabolic process. So if you come across a case like this, for instance, this was referred to us as a possible neuroinflammatory disorder. But looking at the images, very, very symmetric changes. You see involvement of the globus pallidus, the medial thalami and the pulvinar, also involvement of the optic chiasm, mammillary bodies. So there was something odd about it in that it was very, very symmetric. So we raised the possibility of metabolic disorder, including because of the pattern of involvement, biotinidase deficiency. Mitochondrial disorders is something you can put in any differential because they can look like anything. And this finally turned out to be intermittent form of maple syrup urine disease, which is due to partial enzyme deficiency, and it manifests in slightly older children, unlike the neonatal type that we saw before. And that leads us to finally to concept number 7, which is more of a philosophy, I think, which is that not all the diseases read the textbook. So it's important to have an open mind. So what is a pattern-based approach? We tried to answer this question and came up with an algorithmic approach based on the predominant structure involved. So for instance, some disorders tend to involve the gray matter, and this can be further divided into cortical gray matter and deep gray matter. We can further divide that into the deep gray matter into the globus pallidus or the striatum, basal ganglia, and thalamic involvement. And further distinction can be made based on what the underlying imaging abnormality is. So is the gray matter swollen? Is there cytotoxic edema? Is there volume loss over time, as we saw in this case? Or are there malformations, as we can see in peroxisomal disorders? Similarly, with the deep gray structures, what are the signal characteristics on T1 and T2? is that T1 hyperintense has a certain list of differentials, T2 hyperintense have a certain list of differentials. So breaking it down step by step, oftentimes we can come down to a list of differential diagnoses. Similarly, white matter disorders can also be broadly classified into hypomyelinating leukodystrophies and non-hypomyelinating leukodystrophies. These have a fairly, it is an increasing number of, with advances in genetic testing, we are identifying a lot more hypomyelinating leukodystrophy. So this list is probably going to get bigger. But again, depending on involvement, the white matter structures involved, if it's diffuse or if it is selective, there's certain differential diagnosis. If it's associated with calcification, we think of a certain number of conditions. This is probably the largest group, and this is obviously a very busy slide. It can be overwhelming at first, but again, if you break it down to, do they have early subcortical U fiber involvement or late U fiber involvement, and then further subdivide into their head circumference. Macrocephalic kids with early subcortical U fiber involvement have a certain list of differentials. If they are microcephalic, they have another list of differentials. And so in most cases, again, breaking it down step by step, we are able to come down to a differential diagnosis. And in certain cases, and we'll see examples of this like type 1 glutaric aciduria and even Krabbe's disease, for instance, the imaging pattern is very typical and we can make a specific diagnosis. Okay, so just taking out macrocephaly as an example, these are 4 different cases. And again, the common theme to all of them is that they all had macrocephaly. This particular case, as you can see, the operculum is not formed. So we have poor development of the frontal, parietal, and temporal operculum. It typically has this enlarged CSF space over here, which has been described by some authors as a bat wing appearance. In addition, there's involvement of the basal ganglia. So there's putamen globus pallidus and caudate involvement. The thalami are spared, as you can see. The posterior limbs of internal capsule are also spared. But in general, the white matter is abnormal. You see, this is a 6-month-old, you expect to see a bit more myelin here. So there's basal ganglia involvement with underoperculization and abnormal myelination. So these are fairly specific for type 1 glutaric aciduria. These patients can also, because of these enlarged subarachnoid spaces, they have a predisposition to develop subdural hemorrhages, as you can see here, this very thin subdural hemorrhage along the left frontal and temporal convexity. The second case, slightly different pattern. There is the opercula are well formed. Again, similar to this case, there is involvement of the basal ganglia with sparing of the central gray structures, sparing of the thalami. The subcortical U fibers, as you can see, is involved early. So this has an outside in kind of pattern. Similarly, over here at a higher section, you see involvement of the subcortical U fibers. The other thing you can see here is there is an antero-posterior gradient with involvement of the frontal lobe, with frontal lobe white matter involved more severely than the parietal lobe white matter. Again, these are fairly specific for L2 hydroxyglutaric aciduria, which is another metabolic condition with macrocephaly. So using these different clues, a lot of times we are able to come down to a differential diagnosis. The case number 3, for instance, is slightly different because you actually have sparing of the putamen and caudate, but involvement of the globus pallidus, involvement of the thalami, whereas the thalami are spared in these 2 cases. And finally, in this case, MR spectroscopy is diagnostic because you have grossly elevated NAA peak, and these are diagnostic for Canavan's disease. Case number 4, again, macrocephaly with diffuse white matter, signal abnormality, a relatively spared basal ganglia. And the big important clue in this case is these anterior temporal subcortical cysts. So in this context with macrocephaly, the diagnosis would be megalencephalic leukoencephalopathy with subcortical cysts. So moving on to another example, this is pallidal, so involvement of the globus pallidus. So there are certain disease processes that have, again, we spoke about selective vulnerability. So the globus pallidus is quite vulnerable to certain metabolic derangements, including organic acidemias and mitochondrial disorders and iron deposition. So this is quite a common, not common, I mean, this is a well-known presentation of methylmalonic acidemia in an older child, and they usually present with stroke-like symptoms. So it's known as a metabolic stroke, where you have very symmetric involvement of the basal ganglia with, not basal ganglia, but more specifically the globi pallidi with restricted diffusion. Over time, they can be, T2 hyperintense, and they can even cavitate, and they look like chronic infarcts. So very typical of late onset methylmalonic acidemia. In this case, with very anterior predominant signal change, again, it's non-specific, but this should raise the possibility of a metabolic or neurogenetic condition just because of its symmetricity. There's also some calcification in this case. This was a case of mitochondrial disease. The third one is, as you can see, a very young infant would, we do not expect to see normal mineralization at this age, and these gradient echo images show blooming artifact, again involving the globus pallidus. The anterior part of the globus pallidus is more severely involved than the posterior part. So again, this is an important area for iron deposition diseases, in this case with neurodegeneration with brain iron accumulation. And finally, in this case, you see very few things are T1 hyperintense, as we all know. So if we do see T1 hyperintensity, it comes down to a limited number of conditions. In this particular case, you have T1 hyperintensity involving the globi pallidi as well as the anterior pituitary, which is very specific for manganese deposition, in this case with manganese transporter deficiency. Okay, so using some of those concepts that we have seen, let's go back to our first 5 cases and try and come to specific diagnosis. So case number 1, again, born normal encephalopathy on day 7 of life. So we are thinking of something metabolic by the history alone. This is not perinatal HIE. This sounds like something where they were protected in the uterus, and once they are born with either stressors or feeding, because of an enzymatic defect that is now exposed, so to speak, they acutely decompensate and present as an neurological emergency. So on the T2 weighted images, you see there is diffuse involvement of the white matter. There is also a slightly differential signal intensity of the corticospinal tract. So it seems like a slightly different process is affecting these tracts compared with the rest of the white matter. In addition, we see involvement of the thalami. They are swollen. The globus pallidus is involved. There is relative sparing of the caudate and putamen in this case. And the diffusion weighted images are very, very useful. So you see perirolandic cortex that's around the central sulcus there, and perirolandic white matter shows restricted diffusion. So essentially along the corticospinal tract, and also the myelinated structures in the central brain, including the thalami, are involved. You have some involvement maybe of the optic radiation as well, and involvement of the brainstem. and cerebellar white matter. In the brainstem, note involvement of both the ventral and dorsal white matter tracts. It's known as the 4-dot appearance, which is quite typical of maple syrup urine disease. So these features are due to a combination of both vasogenic. So all of this white matter signal change is because of vasogenic edema, which is quite a common theme in acute metabolic decompensation because many of these metabolites are osmotically active. The changes along the corticospinal tract, as we saw before, are due to intramyelinic edema. And the main differentials would be non-ketotic hyperglycemia and methylmalonic acidemia. But if there is one take-home message that I would like you to have from this talk is please remember this pattern. This is very typical for maple syrup urine disease, this degree of swelling. Immediately make the phone call to your clinician. They can start treatment, and the outcomes are excellent. So as in this case, you see follow-up at 5 years of age has a very, very good outcome. Maybe a little bit of residual signal change, but otherwise doing very well. So moving on to case 2, again, we see similar themes. So this is another one of those inborn errors of metabolism presenting in the neonatal period, probably because of a accumulation of a water-soluble toxin. T2 weighted images, again, similarly to previous, you have this diffuse edema, which again is quite common when in patients with acute decompensation. The slightly different thing in this case is there is involvement of the caudate nucleus and parts of the putamen. There's also quite severe involvement of the insular cortex. So you see the normal gray-white matter differentiation in the frontal lobe and the temporal lobe, and that is lost here. There's quite a bit of swelling going on here. And on the diffusion weighted image, we see quite a peculiar pattern of involvement with insular predominance. There's involvement of the cingulate gyrus as well. Not very symmetric, but it involves both sides. And as we come down, we see involvement of the amygdala as well. So these are quite typical, this crenellated appearance, that is involvement of the deep structures of the cortex, is quite specific for urea cycle defects. And there are 5 different enzymes. In this particular case was ornithine transcarbamylase deficiency, but urea cycle defects have a predilection for these structures. I'm not entirely sure why. It probably is due to increased glutamine and glutamate induced excitotoxicity, and the distribution can perhaps be explained by the high concentration of NMDA receptors in these regions at this age. An important point to note here is sparing of the thalami again, which in case of severe HIE, we would not expect the thalami to be spared. MR spectroscopy was not done in this case, but if it was done, you would expect to see a glutamate peak that would, further help establish the diagnosis. Okay, moving on to case 3. So what are the tracts involved here? Again, these are the corticospinal tracts. We see involvement of the medullary pyramids here, again, just prior to decussation of the corticospinal tracts. This is very typical involvement of the hila of the dentate nuclei and the perihilar white matter. So it has this kind of this kind of 3-layered appearance where you are sparing of the dentate, but involvement of the hilus and peridentate white matter. Sagittal T1 weighted image shows enlargement of the optic chiasm. The chorda equina nerve roots are thickened, enlarged, and show enhancement, as we can see on the sagittal and axial weighted images. So the constellation of findings is again fairly specific for Krabbe's disease. The things to look for would be corticospinal tract involvement over time. I mean, this would be a fairly early diagnosis in this case because over time they can have more confluent changes. And in advanced Krabbe's disease, it can look like any other advanced leukodystrophy, and it always gets more difficult to diagnose it once they're at an advanced stage. For example, this particular case, even though depending on genotype phenotype correlations in Krabbe's disease are not very well. I mean, they don't correlate very well with each other. So you can have a similarly aged patient with more severe changes. So it's just important to keep that in mind. And over time, it's important to know that many of these just end up looking like any sort of chronic leukodystrophy with white matter change. So looking at the earlier images always helps in making the differential diagnosis. In this particular case, you can also see this very tigroid appearance. So the differential in this case would also have been metachromatic leukodystrophy. And sometimes it is difficult to specify one single diagnosis. Finally, case number 4, again, the recurring theme here is involvement of the myelinated white matter. But what helps us here, what additional clues help us here is this very thin and foreshortened corpus callosum. And this peak at 3.5 parts per million, which helps us to make a diagnosis of non-ketotic hyperglycemia. And finally, the last case, this is a 6-month-old on treatment for infantile spasms. The spasms are well controlled. So the history is again important here on treatment for infantile spasms. Vigabatrin is one of the most commonly used drugs used for spasms. And the fact that the spasms are well controlled, the baby is otherwise well asymptomatic. These are fairly common. We see them in up to about 30% of patients on Vigabatrin. Again, the underlying pathophysiology is intramyelinic edema. So it is an analog of GABA, and being an analog of GABA, it's like an inhibitory neurotransmitter, and for some reason it causes intramyelinic edema, similar to what we see with MSUD, etc., except that the distribution is slightly different, tends to involve the central structures a lot more. So globus pallidus, fornicial, thalamic involvement, brainstem involvement is very common. So instead of calling this as a metabolic disease or even a toxic accumulation, the history is important. So once we know that they're on treatment for infantile spasms, and we talk to the clinician says they are completely well and fine. So we just label this as Vigabatrin related MRI abnormalities. Some authors have called it Vigabatrin toxicity, which I think is an incorrect term, because if they're asymptomatic, you would not essentially call them as being toxic. So most of them, even though the findings look quite startling, they are asymptomatic and they do not require dose modification. So to conclude, clinico-radiological phenotype and pattern-based evaluation helps us in narrowing down the differential diagnosis in most cases. And we need to take we need to find as many clues as possible, both in the history and in the clinical presentation. I find it very useful to go through the patient's charts and speak to clinicians directly, to get those 1 or 2 important pieces of information that help tie it down together. Early recognition, again, is important because we want to initiate treatment. We want to cause reversal of these imaging findings and provide the best possible functional outcome for the patient. That is my talk. Thanks everyone for your attention. If there are any questions, I'll be happy to take them. Also, feel free to email me and I'll be happy to send you the paper with the algorithms.